All right, so I say we get started, and then we can have some people join us. Good morning, everybody. My name is Trish Olson, and I'm with SK Life Science, and I'm also a volunteer here for Epilepsy Awareness Expo for several years now. It's a pleasure always to work this event, and I also have the unique pleasure of introducing Dr. James Park. Dr. James Park is an epileptologist at the Pickup Neurosciences Center and the Epilepsy Program here at HOAG Hospital in Newport Beach, California. He is originally from the East Coast and did all of his training there, including completing his fellowship at Thomas Jefferson University, which is one of the premier epilepsy programs in the nation. Dr. Park brings his expertise and unique perspective to Orange County and actually was instrumental in assisting HOAG in getting their level 4 credentialing for epilepsy program. We are going to talk today, Dr. Park actually is going to give a talk today on Epilepsy 101, why an epileptologist and why a level 4 center. And again, feel free to put your questions in the chat box, and Dr. Park, the floor is yours.
Thank you. Thanks for having me in terms of just giving this talk, and we're just going to go over the very basics of kind of epilepsy, what it means, and kind of treatments, and really towards the end describing kind of why to see an epileptologist and why to consider a level 4 center, as Trish said. So moving forward here. Disclosures, I do speak for SK Life Science for Xcopri, which is their new drug. So what is a seizure and what is epilepsy? A seizure is a sudden surge of abnormal electrical activity in the brain, and that really can cause a variety of symptoms. So you can imagine if you're, that your brain controls every little thing that your body does. So depending on where it starts and where it spreads, you can have different symptoms with that. So, no seizure is alike. While there are kind of common things and patients who have similar types of seizures, sometimes they can be really random and out there too. So again, it's more about, to us, kind of, is it a stereotyped symptoms and kind of does it happen the same way every single time? That makes us suspicious about seizures. And then a diagnosis of epilepsy is really made when someone has an increased risk for recurrent seizures. So, people can potentially have one seizure and only have that seizure ever in their lifetime and not really get a diagnosis of epilepsy and need treatment. But when according to the International League of Epilepsy, when you've had 2 or more seizures separated by 24 hours or at least 24 hours apart, then you get a diagnosis of epilepsy, because that's, again, your brain's way of telling us that it has a risk for recurrence. Or if you have one seizure and then have something suggesting, have something suggesting that you have an increased risk for a seizure. So they quote like 60%, greater than 60% chance, but usually that means if you have an abnormal test or something to say that we think that you have a greater chance. Or you get diagnosed with an epilepsy syndrome, whether that be some kind of genetic type of epilepsy or just kind of the classic kind of childhood or kind of teenage onset epilepsies. Then again, you would get diagnosed with that. So how is epilepsy diagnosed exactly? So the main part of it is really the history. So, sitting down and talking with your neurologist or epileptologist and finding out, what are the episodes like, what are the symptoms that you have, how often have they occurred, when did they happen, those kinds of things. Videos now in the day of technology are helpful. Everyone has cell phones, and just taking a video sometimes of catching what the seizures look like may give us sometimes an idea of kind of what, what it looks like, just because sometimes descriptions aren't enough. And so that can be helpful sometimes when, families or friends kind of bring those in for the visit. And then other testing that we get are typically, one is called an EEG, or an electroencephalogram, which is the electrodes that go on the outside of the head and really detect your brain waves. And there's different types. There's a routine EEG, which is anywhere from kind of 20 minutes to an hour. Ambulatory Eegs, which are 24 hours or longer. And then really the gold standard of sometimes diagnosis is continuous video EEG monitoring done in the hospital setting. And what you get is kind of this kind of picture over here, where all these letters and numbers mean different things about where the electrode is on the head. And you may get a kind of these hints or discharges to tell us there's a part of the brain that is irritable. So if I saw someone who had one seizure and had this kind of EEG, again, I would say, okay, you have an increased risk of seizures based off of this, and that you need treatment. The other thing that we usually get in patients with new onset seizures is some sort of imaging, usually an MRI, a high quality MRI, to basically rule out any structural abnormalities. So that might be a cause for seizure. So that can be anything from, strokes, tumors, those kinds of things, or even developmental abnormalities, things that have been there since patients were born and just didn't become active until later on in life. And so these are kind of very subtle things that we may be looking for that may, again, suggest someone has an increased risk of seizures or not. So what are the different types of seizures that someone can have? So the old terminology was actually, and you'll still hear them now, things like grand mal or petit mal or complex partial, simple partial seizures. That's kind of the old terminology, but often can get confusing because it's hard to, remember what was what. And sometimes symptoms can get confused for different types of seizures. Like, for instance, patients often confuse complex partial seizures with absence seizures because people stare and just are unresponsive, but they meant two completely different things. And so in a way to kind of standardize everything and to make it a little bit more clear what type of epilepsy someone has, the International League Against Epilepsy in 2017 created this new kind of classification. So again, it's either focal onset, generalized onset, or unknown. And focal onset, you can either lose awareness or maintain awareness. And then you can have all these different types of kind of symptoms with it, or movements with it. Generalized onset, same thing, different types of movements or symptoms, and then unknown, a similar thing. So, and then when someone has a focal seizure, but then becomes a tonic-clonic or a grand mal seizure, that's when we call it this focal to bilateral tonic-clonic. So it's a lot of words. It complicates it a little bit in terms of that, but it just makes it more kind of clear as to what type of epilepsy you have. That's important because treatment will really depend on what type of epilepsy we think you have. So certain medications which are narrow spectrum may only work for focal onset, or actually may worsen some generalized onset epilepsy. So it's really going to be important to kind of discern from the history and everything to say what type of seizure epilepsy we think a patient has. And this is just kind of a picture of showing kind of that same thing. So focal epilepsy is seizure starting in one spot or multiple spots and spreading to other parts of the brain. Focal to bilateral tonic-clonic or secondarily generalized seizure is basically you start in one spot, kind of get to some deeper part of the brain, and it spreads to the whole brain. Whereas a generalized epilepsy kind of starts deep and spreads to the whole brain all at once. And so again, treatment is going to really change depending on what type of epilepsy we think you have. So what are common causes of seizures? The main one people think about is genetic causes, right? So this is an example of kind of what's called a sodium channel, which is used in the excitation of neurons. And so someone can have a mutation in this kind of thing, and it might not be working properly, and people can have very bad seizures because of what we call channelopathies. There's other genetics, for instance, that can affect things like the mitochondria. So that can actually be considered what's called a metabolic cause. So mitochondria are used in kind of creating energy for our cells in our body. And if there's something wrong with it, again, then things may not be working properly. So a lot of genetic causes that cause issues with this kind of thing can, again, be a cause for seizures. And these typically tend to be in younger patients, like from birth or childhood. And then the big part of kind of really epilepsy, especially in adults, is structural abnormalities. So this is actually structural abnormalities in a child, because this is kind of genetic causes of it. But you can see this kind of ribbon on the inside of the brain that's supposed to be actually more white. Same thing here. And this is what we call bubble cortex. And some genetic causes essentially these cells to not migrate properly. So there may be more subtle kind of forms of this in some patients that we see, even like just a small portion of the brain that maybe didn't migrate properly when they were born. And at some point in the future, that could be a cause for seizures. This is a much more common thing that we see in kind of young adults and in the adult population. This is what we call mesial temporal sclerosis. Essentially, this middle portion of the temporal lobe, which is called the hippocampus, you can see here, this side looks kind of more, kind of smaller compared to the other side and brighter compared to the other side. And there's some scarring of that tissue, and this can be a common cause of temporal lobe epilepsy. You have other kind of causes that can be acquired or again, may have been there and not just been presented until later. And this kind of subtle thing can sometimes be missed on an MRI even, just because it's quickly scrolling through, you may miss it. But this little outpouching of the brain here, there's a skull defect, which allows that brain to kind of stick through. And this is what's called an encephalocele. And this can, again, be a cause for seizures too, just because that brain is getting irritated by having kind of getting stuck in that little space. You can have people have abnormal blood vessels. This is a cavernoma, so an abnormal tangle of blood vessels that can sometimes bleed and again cause surrounding tissue to be abnormal and be a cause for seizures. This is a stroke. In older patients who develop seizures, stroke can be a common cause because again, you're causing damage to the brain, which then can be irritable and cause seizures in older patients. And then another thing that can happen in older patients is tumors. So this is a glioma or a glioblastoma, for instance. Other than structural, there's a couple other ones here. Idiopathic, meaning just sometimes we don't know. Sometimes MRIs look completely normal and there still can be recurrent seizures that happen and we don't always know why. Part of this group also tends, their new and an emerging field in this is actually sometimes autoimmune causes for seizures too, which is pretty rare, but it does happen. And then lastly, there's a kind of almost separate category of seizures, what we call non-epileptic seizures. And these are actually not electrographic seizures or not epileptic seizures, not because of abnormal electrical activity in the brain, but because of stress or trauma or something that happened in the past and can, again, really be a subconscious thing that happens. And people have what look like very violent kind of seizures, even falling and things, but we find that it's actually not due to abnormalities in the brain. And so sometimes that's even a diagnosis that we have to kind of differentiate between, and some people can actually have both. So again, it's important to differentiate them because the treatment will be very different. So what is the prevalence and toll of epilepsy? So the statistic is that 1 in 26 people will develop epilepsy in their lifetime. So it's actually very common. That number surprises people because you don't really hear about epilepsy as much as, say, other diseases or kind of more debilitating diseases as people think, like with ALS, for instance. But epilepsy is very, very common. And it's estimated that 3.4 million people in the US live with epilepsy, and there's 150,000 new cases each year. Worldwide, 65 million people, so a very significant number. Sorry. And in terms of the toll of epilepsy, in the US, the annual number of deaths due to epilepsy is actually comparable to breast cancer. And the years of potential life loss is actually only second to stroke. So you can imagine that epilepsy gets diagnosed in young people, children often, And again, if seizures are not controlled, then there's a kind of high morbidity and mortality with that potentially. And you're just losing many years of kind of productivity and things, for instance. So, and of this subset, really, the ones that we have to worry about are patients with uncontrolled epilepsy. So meaning medications and treatments are not working to control seizures, and they have they've been shown to have a 2 to 10 times increased risk of premature death. And this is just a graph kind of showing you that, again, general epilepsy population does have a higher risk compared to just normal. But from there, if you have patients who have seizures that are not controlled or are considered, again, candidates for surgery, that risk significantly increases. So again, epilepsy can have a big impact on a person's life. So what about the treatment of epilepsy? So what do we do then? Really, the mainstay of treatment is medications. And what we see over the years and decades is that we've had this explosion of medications that are available to us. So, up until the 1990s or so, we only had kind of a handful of medications. But since then, you almost kind of had this kind of parabolic appearance to the graph where you just have an exponential kind of growth in what we have available. And that is only beneficial to our patients because not only do you have kind of different medications to try to, in case, patients are not tolerating it, but also different mechanisms of action and again, different combinations that we can use sometimes to try and treat seizures. And with newer medications, we're actually getting potentially less side effects and even with some of these newer ones having kind of never seen before seen efficacy, that a lot of these drugs, let's say, all has similar efficacy over the years, but some of these newer ones like fenfluramine and cenobamate, for instance, in the trials, we've been seeing very high efficacy in patients, which we've never kind of seen before. So again, better design drugs and newer ways of kind of developing things that may change kind of the landscape in the future. This is just a picture showing you, again, the different drugs and the different ways that they act. There's a whole host of kind of channels and kind of different parts of the neuron that the medications work on. And so this is where oftentimes we as epileptologists are kind of trying to manage what we're using, that we're not using medications that are kind of attacking the same thing sometimes, because that just increases the risk of side effects. But that being said, just because one sodium channel agent, for instance, didn't work, doesn't mean another one won't work. So again, we're trying to pick kind of sometimes based on a lot of these things, and it's a bit of a trial and error, but the fact that we have a whole kind of bunch of medications to try, again, it's beneficial, I think, in the long term to our patients. So what about kind of the refractory or what we call drug-resistant epilepsy cases? So what does that mean? So when a patient has failed to become seizure-free with an adequate trial of 2 or more seizure medications, they're considered refractory. So and adequate means, again, up to higher doses, tolerating it well, being compliant with it, that the medication was chosen properly, right, for the seizure type. So if it was the wrong type for that seizure and potentially made it worse, that you can't say that that's failed. And then any triggers that could have caused seizures, for instance, sleep deprivation, alcohol or drug use, like those kinds of things can't have kind of affected the seizure control. And so again, if those things have all been kind of ruled out, exacerbating causes have been ruled out, and a patient has tried higher doses of a medication and still had seizures through that, then again, we consider that medication as having failed. And basically this kind of rule of thumb that we came up with that we use came from actually these kind of landmark trials, initially looking at patients from 84 to 97 in one center in Scotland. And what they showed is with the first medication in newly diagnosed patient, you get about 50% of people who are well controlled on that medication. You take the people who didn't do well or didn't tolerate it, let's say, and put them on a second or third medication or even multiple medications, you get maybe about 15 to 20% more of patients. So about 2/3 are well controlled with medications, but it leaves this 1/3 of epilepsy patients as refractory. And then the question came up, okay, this looked into the 90s. There really wasn't that many new drugs available then. Maybe the new drugs are better because we tolerate it better and they use different mechanisms. What do we see then? So they actually continued the study and went all the way out to even 2014 when we had a lot of these newer medications. And we see that the graph is really, or the pie chart really hasn't changed at all. That still a third of patients with epilepsy have refractory epilepsy. So medications are not working. So it's not about the drug, it's not about the mechanism and things like that. It's really something about the epilepsy and the network that's involved is making it so that they're not responding to medications. So what do we do for these patients? Actually, before we go through that, this is just kind of showing you the probability with each medication. So again, the first anti-epileptic drug is about 50% probability of achieving seizure freedom. The second and third and so forth, you get another 10, 15%, like I said. But when you fail 2 or more, you really are getting less than 5% chance of that working. And each drug you keep on adding there is less than 1% chance. So, when really at that, once 2 medications have failed, we should be moving to something else, not just continuing to spin our wheels and try medication after medication, just because, again, we see the risk of continuing to have seizures in terms of premature death, and even we know things like memory and cognition and things can be affected over time. So the treatment of refractory epilepsy is kind of the mainstay is epilepsy surgery. Whether that means resection or kind of these other procedures, newer things like laser ablation, devices or what we call neuromodulatory devices, VNS, DBS, RNS. These are kind of really the mainstay of our refractory patients. And it requires a whole kind of battery and bunch of testing before we get there, as you kind of see in this algorithm here. First thing is just trying to capture seizures on EEG on the outside of the head to see, which side they're coming from, what region at least. Getting high quality imaging, like I said, like MRIs. We do a whole battery of tests called neuropsychological testing. So it's testing memory, language, those kinds of things to see not only what the baseline is, but also if one function is not working, that would suggest maybe that side of the brain has been affected by seizures. So that gives us a hint sometimes as to where to go or look. And then other testing like fMRI or WADA, again, to test memory, language and things like that. Sometimes additional testing like MEG and SPECT and PET-CTs are needed. And from there, we may have enough information to decide to go straight to surgery, or sometimes we need to decide that seizures need to be further localized kind of to a smaller area. And that's where we do this invasive monitoring. We still do what's called kind of grids and strips, which is taking the skull off and laying down electrodes on top of the head, which is kind of the older way of doing things. And some patients that's required. Kind of newer way that a lot of centers in the US are now moving to, similar to our French colleagues who've been doing this a long time, is we're doing stereo EEG. So it's essentially a minimally invasive procedure where you drill holes and put electrodes into the brain, and you're covering various spots with that. And this actually allows us to sample deeper areas of the brain, which we never did before when you just, or didn't do as much when you just did the grids on top of the brain. But also this is shown to have less complications, less infection and less bleeding and all those kinds of things. And nowadays we're doing it with the assistance of robots to basically kind of decrease the amount of time it takes to put in electrodes, but also to improve the accuracy and make sure that the electrodes are being placed where we say they're being placed. So this is, again, kind of the main thing that would be done for our refractory or drug-resistant epilepsy cases. But sometimes surgery is not 100% either. So then where do we go from there? There are clinical trials with different medications and treatments. And in some cases, like I said, when we think there might be an autoimmune cause, we may even try immunotherapy. So medications that suppress the immune system to see if seizures might get better with that. So what is an epileptologist? Epileptologist is a neurologist. They've done their neurology residency and everything, but from there you actually do an additional 1 to 2 years of fellowship training, specifically in epilepsy. And so that entails kind of extensive experience and just day-to-day reading EEGs, these squiggly lines that you saw earlier, just reading it day in and day out, and just knowing how to identify different things with that. Treating complex epilepsy cases. So, usually the patients who are coming into high-level centers are patients who, let's say, have a complicated medical history along with epilepsy, or have epilepsy that hasn't been controlled and things. So again, they're coming and as in training, you're seeing a lot of these patients and getting that experience. And lastly, again, is planning epilepsy surgeries, which again, I said is the mainstay for treating those refractory cases. In contrast, a neurologist, a general neurologist, without any fellowship training, I would say, spends as little as 1 to 2 months in each year of their residency training, focusing on EEG and epilepsy. So for instance, where I did my residency, I think I spent 1 month each year just being there reading EEGs, but again, it's not the same as doing it day in and day out. So, while our general neurology colleagues do treat epilepsy patients and do read EEGs and all these things, there is a kind of an experience, I would say, a gap in terms of epilepsy and an epileptologist and a general neurologist. So, there may be times that I've seen a patient and I, let's say, thought differently than a general neurologist, or read an EEG and thought differently than some of my colleagues. So again, that does happen. And so as you can imagine, the brainwaves are just these squiggly lines. So again, it's left up to interpretation. So again, experience there can sometimes help. So when should you see an epileptologist? So if you have seizures that are well controlled by seizure medications, then following with a general neurologist is fine, because you're doing well. The medication's working, right? You don't need a subspecialist really to see over your, look over your case or anything, because the medication isn't working for you. So about, like I said, 2/3 of those patients, or even that first 50% of the patients who are controlled by that first med, there's really not a huge need to see an epilepsy doctor. But if seizures are not controlled, that's the most important one. If you're having issues with your medication and want another opinion about it, or if there's a question about the diagnosis, right, then you should consider seeing an epileptologist. Because again, as I showed you with the pictures of all the different medications and different ways that they work, there's all these interactions that maybe a general neurologist may not know about because they don't experience it as often as we do. Or let's say, there's a question about the diagnosis because, really you have a generalized epilepsy, but are being put on a medication that works for more focal epilepsies. So that could be making things worse sometimes. So that, and again, that's something that we see sometimes. And just part of it is, again, experience and training. And then lastly, I would say an important group of patients that should see an epileptologist are women of childbearing age who are thinking about pregnancy or are pregnant and should see an epilepsy doctor kind of right away. The reason for this is that seizure medications and levels can really change dramatically during pregnancy because your metabolism is more active and things, your drugs could be broken down faster. And so medications like lamotrigine or levetiracetam, for instance, can drop throughout the pregnancy. And really, our goal is to monitor it closely and make sure it stays at a certain level. And so that's why, whenever I see a woman of childbearing age, if they're, 16 or 21 or whatever, I always talk to them about this and say, I know this isn't anything in the near future, but when you think about pregnancy, it should be a planned thing, number one, because we want to make sure seizures are as well controlled as possible on as low a dose of a medication as possible. And we also want to have just drug levels so that we see where your baseline is, where your seizures are controlled. Because then once you become pregnant, that's where we're going to aim for to keep it at. And so sometimes, again, we do get stuck behind the 8 ball because they come after pregnancy, or let's say it's their second pregnancy and they just didn't know with their first pregnancy. But I did have patients, for instance, who during their first pregnancy, their doctors never changed the dose and they ended up having seizures while pregnant, which is actually worse for the baby than any medication side effects could cause. So again, women of childbearing age who are looking to get pregnant or are pregnant should see an epileptologist, even for just that pregnancy, I would say. So what are the different levels of for epilepsy centers then? What does a level 4 actually mean? So the National Association of Epilepsy Centers, the NAEC, actually is the governing body that accredits the epilepsy centers. So they consider level 1 as basically like an ER visit or senior primary care for a seizure kind of evaluation. Level 2 care is really seeing a general neurologist and getting started on treatment or being referred out, I guess. Level 3 is providing kind of the basic range of services for treating refractory patients. So these level 3 centers may actually be doing surgeries and things as well. And they say actually level 4 is then kind of providing the most complex care for refractory patients. So that means kind of all the services, all the imaging, the invasive monitoring, surgical procedures that you need to treat refractory epilepsy, you kind of have that all available. So really, if you look at it, even HOAG, when we went from level 3 to level 4, level 3, we were oftentimes doing the same procedures and everything, but just getting the number of patients to be seen is what gets patients to centers to that level 4 center. That being said, not all level 4 centers are equal either. It really will depend on kind of what their surgical volume and those kinds of things are. So for instance, where I did my residency, they had a level 4 epilepsy centers. Most academic centers are because of, again, the number of patients and things that they're seeing. However, some centers may only do like a handful of surgeries a year, versus some centers, for instance, where I did my fellowship, were known as kind of the biggest centers in the country or even the world, and they're doing hundreds of surgeries a year, right? So there can be, again, a bit of a gap in terms of, not only experience, but also, again, how many cases that they're doing. So that's something also I would say, if you're looking for a level 4 center and let's say having surgery, something to look into, because again, different centers may provide different things based on that. And so again, this is a general kind of guideline for the levels. So why should you go to a level 4 epilepsy center? So again, they provide the most comprehensive care for all types of epilepsy. You really are getting the expertise of neurologists, neuropsychologists, neurosurgeons who are all specifically trained in epilepsy. And then you get the advanced monitoring and surgical techniques that you may not get at other places, including kind of the newer minimally invasive procedures like stereo EEG and laser ablation. And then a big part of it is also clinical trials, that if you're a big center or an academic center, for instance, and part of clinical trials, that's just another avenue for our patients who are not controlled to kind of get further care that maybe they wouldn't be able to get other places. And ultimately, again, the goal for all of us is seizure freedom. So if you're not seizure free, then whether your doctor has referred you or not, I think it's something to kind of be looking into in terms of being referred to a specialist to kind of take another look. So again, the statistics saying like how long it takes a patient to get to a specialist with refractory epilepsy is actually, unfortunately, a very long time. And so this is just something that hopefully this kind of thing where we educate patients and other physicians about it, they're able to get them quicker to places that need to go to get the treatment that they need. So this is our team at HOAG, and you know, again, everyone kind of instrumental in getting us to that level 4 designation, and we've been kind of continuing to grow and hopefully providing kind of excellent care here in Orange County. So that's it for me. If you have any questions, feel free to ask on the chat box, or and Trish can ask them, or we can even unmute and ask if you want.
Thank you, Dr. Park. That was really great information on understanding the difference between the and also the importance of, you know, patients seeking out an epilepsy center, specifically if there are seizures or uncontrolled. So thank you. Again, yes, feel free. This is a great opportunity to have Dr. Park, you know, right here. Any question is a great question. Don't be shy. And you have the option again of using the chat box or just unmuting, and feel free to go ahead and ask. Give it a minute here while people are typing, maybe. Let's see. Don't see anything coming in yet.
That's okay.
Here we go. So we have one question here. Hi, thank you for your time. My daughter was recently diagnosed with JME. Might be a part 2 coming, or just looking for guidance on that. Maybe while we're waiting, maybe want to, we can explain to the rest what JME is.
Yeah, so JME stands for juvenile myoclonic epilepsy. So it's one of the generalized epilepsy or genetic type of epilepsies that we talked about. And it typically presents in kind of early teenage, late teenage years. The kind of the classic picture that they give you for boards and things, for instance, is like a teenager who goes off to college and starts going to bed late or being sleep deprived because they're studying or partying or whatever, right? And the next morning they have their first kind of tonic-clonic seizure, and so it has a very classic kind of looking EEG pattern to it. You know, clinically, that would be kind of the picture. They may sometimes have what we call kind of myoclonic jerks. That's hence the name. You know, let's say if they were sleep deprived or early morning and things like that. As she said, yeah, it has jerks, and these are warnings that help us. And so thankfully, though, most JME cases are well controlled with medications. And it's just about kind of trying the different ones. The hard part with women that have JME or young women like Nancy's daughter is that, can we get them on a medication that is also safe to use later on in pregnancy? So we, again, even though she's 17, we always think about that ahead of time. So really the best medication that has been shown to work, or the medication that's been shown to work the best for JME is a medication called Depakote or divalproex, but that has actually the worst kind of safety data for pregnancy in terms of teratogenicity risk. So again, but some patients, that's what works for them, and that, you know, you can't really have them on anything else. So everything is kind of a balance of risk and benefit, and again, what works for each individual patient. So And it says, how can I work with her, or any advice on how to help her with sleep?
Sorry. Hi, can you hear me now?
It's a little choppy, but
Can you hear me?
yes.
Yes.
Oh, let me try. Can you, better?
Yes.
How's this?
Good.
Hold on. Sorry. Okay, hold on.
Happy texting.
1 second. Let me try out here. Hold on. Can you hear me now?
Yes.
Yeah.
Can you hear me? Okay,
Yes.
sorry. Hi. So I have a 4-year-old running around, so that's why it was making it harder for me to text and stuff. But I have a question. My daughter just turned 17, and she is a senior. And you know, this whole pandemic has actually been like a blessing, a silver lining, I should say. You know, where we've been struggling the last year with her classes. You know, this just started last year, and it's, you know, she's a straight A student, and you know, now all this. But what we're trying to figure out is, what would you recommend as far as like the best approach? Like sometimes she withholds information, like not letting us know she's been having jerks.
Yeah.
Because her whole thing is she wants to get a license, and her doctor told her she needs to be seizure free for 6 months or a year. I don't know. We're in California, so I don't know what the rules are, but that's her whole thing. But so she won't tell us. But lately she's been having more jerks happening, and I don't know. I know sleep is a big thing, but I tell her go to bed, but you can't make someone go to sleep, you know? So I'm just trying to figure out what kind of things we can do to help, where she's more honest about what she's feeling, and then what we can do to help make sure she, you know, she's getting the rest that she needs.
I mean, first thing is, you know, little myoclonic jerks, while they technically are epileptic seizures, like you see discharges in the brain when that happens, you know, they're not, most times they're not causing they're not causing kind of loss of awareness or causing too much problem. So, you know, the occasional jerk, to me, at least if I were seeing a JME patient, would be okay. And as you said, sleep is a big part of that. So part of it is just her realizing her diagnosis and realizing that she's an epilepsy patient and needs the rest, good rest every night, because again, that could potentially cause bigger seizures. In terms of driving, California state law is actually, you have to be seizure free for 3 to 6 months to be able to get a license. So, so the other part of this is, if she wants to drive, and again, she has to show that she's seizure free, but if she gets her license, but then has a seizure, let's say because she doesn't sleep the night before or missed meds or whatever, technically that still takes your license away again, because again, that's not anything a doctor prescribes, it's not anything we did, but it's a lifestyle thing sometimes that causes it. And again, that's something that individual patients have to realize and try to manage themselves so that, again, seizures don't happen. So according to, again, California, regardless of what exacerbated it, any seizure can potentially take the license away. The one kind of loophole or one thing would be if, let's say, I told them to cut down on their meds and they had a seizure. So so that might be a driving factor, right? That might, the driving might be a way to say, hey, like, you really need to get good sleep, because if you have a seizure, guess what? You're going to lose your license again for 6 months, let's say. So
when she must have had 10 last year, full tonic, you know, and or 8. Anyways, it was a lot, and we knew that the more these little jerks would happen, the more, you know, it's a warning, like almost like the big earthquake is coming soon. So we're trying to avoid that, but she's really good. She's, like I said, a straight A student and stuff like that. But when she goes to bed, she'll have a really hard time sleeping, and she'll be up for another hour or two reading. You know, she doesn't do stuff on her phone, but then we can see that we start to struggle. So that's what I was just trying to figure out, like any advice with.
And part of this is, again, talking with your doctors about adjusting medications and things too. You know,
Okay.
for instance, for me, if I have a patient who has a seizure because they were sleep deprived one day, I might still increase the medications because I want to cover for those situations still. That life happens. You know, we can't always get good rest every night, and so if that someone gets sleep deprived, they had a seizure, that's not great either. So again,
Yeah.
I may increase medications, or let's say add a second medication on if you're already on a high dose, just to try and cover for that too. But again, everyone's a little bit different. So, and everyone's way of doing things is a little different, but
Yeah.
to think of, and like you said, kind of a big part of it is just she has to take kind of ownership of her health and try to make sure to minimize those things if she can. And yeah, tonic-clonic seizures, that many is not good. And again, uncontrolled seizures can affect memory and cognition over time. And like we talked about, they do increase risk